I want those days of 2 and 3-year-olds with Down syndrome being spoon-fed purees by an adult to be gone.
Yeah.
Because I just don't think there's any reason for it.
We welcome you all to Talk the Talk. My name is Janine Steen.
And I'm Toni-Ann and
the Masters of Myofunctional Therapy.
Together, we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving.
Hello, and thank you for joining me on Talk the Talk. Also joining us today is Jill Rabin, a pediatric speech language pathologist and international board certified lactation consultant with over 39 years of experience working with infants and their families. Jill is the creator of the Adapted Baby-Led Weaning approach, a method designed to help all babies, especially those at higher risk or with feeding challenges, safely develop the skills they need to self-feed. Through her clinical work, teaching, and her co-authored book, Your Baby Can Self-Feed Too, she's helped reshape how clinicians and parents think about feeding, not just as nutrition, but as a foundation for development, independence, and long-term success. Thank you, Jill, so much for joining me on this episode of Talk the Talk.
Thank you so much for having me. I'm really excited to talk to you today.
Yes, we get to talk one time a month on Zoom for our Oral Motor Institute board meeting. So it's always nice to chat there, but to have you on this episode means a lot to me. So thank you.
Thank you.
Yeah. So if you could start by telling the audience a little bit more about you and what has kind of led you into this path of your career, and when you kind of realized you had this special interest in working with infants and feeding.
So I've been in the field for 39 years. And when I started a long time ago, way before probably many of you were even born, I was educated in Boston. I went to Boston University. And back then on the East Coast, nobody did any feeding back then. The occupational therapist did feeding on the East Coast. I knew nothing about feeding in grad school. I learned nothing clinically, academically, and I did a lot of 0 to 3. I knew 0 to 3 was going to be the population that I wanted to target, but I really didn't know anything about feeding. And I moved to Chicago in the late 80s. And my first job, I worked in a 0 to 3 program twice a week and a 3 to 21 program 3 days a week. In that 3 to 21 program, there were a lot of kids that would come. They were kids that came there for the day. It was like a therapeutic day school. And they had significant feeding issues. And part of my job was to go in there at lunchtime and help the teachers and all the staff to do feeding, which was a little scary because I knew absolutely nothing. And I will tell you that really where most of my knowledge came from initially was on that job. And I had a speech pathology assistant that worked with me. I learned so much from her. She was very, very, very experienced. And we worked with a lot of kids with cerebral palsy. We don't see cerebral palsy as much these days, but that was a lot of the clientele that we worked with. And those were really scary kids to feed. And that's really where I kind of jumped right in and learned that. And I did that job for a year. And then I went on to work in a hospital where I worked in a NICU, a PICU, and I did swallow studies, and feeding really just became a huge part of what I did every day. So that's what sparked the interest in feeding.
Wow. So it's kind of like feeding found you in a way. And then
Yes.
you realize how much you loved it. I'm sure seeing the older children or young adults with feeding issues kind of can allow you to see how important it is to target it when they are in that 0 to 3 range so that they don't look like that when they're 15, 16, 17 years old.
Yes. And I think what's really interesting when I think back to way back then, G-tubes were not as big of a thing back then. You were feeding these kids, like a lot of kids who were aspirating and really struggling with chewing. It was really scary. It was scary to feed those kids. So I felt like if I could feed those kids and learn what to do with them, I felt like I could do anything. But really, if we start early with children who we know, especially those that we know are going to have feeding challenges, the impact we can make is huge. We'll talk about that a little bit later, but to me, that's one of the most important things that I want to impart to therapists is children should be seen from the onset. There is so much that you do long before a solid piece of food ever touches a baby's lips.
Definitely. Yes. So speech was your first degree, and then you
Mhm.
went into your IBCLC. How did that happen?
That happened because I worked in a hospital. I worked in the NICU, and I actually established a program in the NICU. We had a standing order for every baby that was medically stable, where we would do a whole protocol in helping them transition to bottle feeding. It was breast was not even discussed. And
Wow.
even I'd say even today, breastfeeding is much more encouraged in NICUs, but it's still bottle schedule amount is very important in the NICU scenario, right? We have to make sure they're gaining and getting enough. So I worked in that NICU. I had this established program where we would offer gloved finger or pacifiers along with gavage feedings to help babies swallow, coordinate, suck, swallow, breathe. But breastfeeding was not something we really even talked about. I knew nothing about it. And I even remember, and I'm so embarrassed now to even think this, like whenever the Medela was one of the only companies that did breast pumps back
Okay.
then. And they
Yeah.
would always come to call on me and show me their products. I'm like, oh, here come those breastfeeding people again. And I was so immature and like
Wow.
didn't realize, at that I was in my 20s. I didn't know. So I became pregnant with my first child. And I remember I was in a prenatal breastfeeding class. And as the lactation consultant was talking about breastfeeding and the impact of breast milk and how it's used for very sick babies. I just remember like I felt really flushed because I was so embarrassed that I worked in a NICU with the sickest babies and I knew absolutely nothing at all about breastfeeding. And I should be the one advocating for that. So I decided after I had my daughter, I was going to pursue lactation just so that could be part of what I did. So the crazy thing that happened is when I returned to work after my maternity leave, they had just hired a lactation consultant for the NICU. And I speak Spanish. So
Okay.
we had a lot of Spanish speaking clientele there. And I used to do a lot of patients with her in conjunction with her. And I would translate a lot. And I would talk about what we were doing as speech pathologists. I would watch what she would do to help a mom get ready for breastfeeding in terms of maintaining her milk supply. I started going into the very hospital that I worked at on weekends as a volunteer with the lactation consultants. And that's how I acquired my hours. You could never do that today, but I
Okay.
was able to do that. She encouraged me to become a breast pump rental station. I had a breast pump rental station out of my house.
Okay.
And I just, within 4 years, I was able to sit for the board exam. And then I became a board certified lactation consultant. And interestingly, I worked at the hospital for 12 years as a speech pathologist. My 13th year, I switched over and I worked as a lactation consultant for them. And
Wow.
then I've worked in 2 additional hospitals here in the Chicagoland area as just a lactation consultant. And I will tell you that they didn't want to hire me in all 3 places because each time they'd say, well, we hire nurses and dietitians. And so we changed the job description to include speech pathologists. So now it's very different. There's so many speech pathologists that are becoming IBCLCs, but back then you had to really kind of forge your way into that profession.
Wow.
So
Amazing. Yeah.
yes, and I use both of my professions together quite frequently. I work with a lot of complex breastfeeding dyads. I'll start with babies with Down syndrome as infants. I'll even work with moms prenatally on how to prepare. And I do a live virtual free breastfeeding support group for pregnant, pumping, and breastfeeding moms of babies with Down syndrome through the Massachusetts Down Syndrome Congress for a group called Julia's Way.
Okay.
And I have a co-moderator who's an IBCLC and a mom of a child with Down syndrome. And we work with people all over the United States, sometimes out of the country, that come to this group. And we really feel like in the past 5 years that we've been doing it, we are getting babies with Down syndrome that would never have breastfed before to get to the breast.
Oh my
So
goodness.
it's very exciting. One of the biggest obstacles we have is the lack of correct information that is given to these parents about whether or not their baby with Down syndrome could breastfeed.
Wow. Wow. That's amazing. That has to be the most rewarding of all the things. And,
Yes.
you mentioned how you didn't know, right? But it's not a part of
Mhm.
our curriculum as SLPs. And we go through 6 years of education, yet we really don't hear anything about bottle feeding or breastfeeding or, being able to support that. I have gone through I have my CLC, so I'm a certified lactation counselor on top of my speech, and definitely IBCLC is, something I'm hoping to move toward, but it's great. I feel like they go so well together.
They do. And I feel like there's things that I see because I'm looking at things with a different lens.
Mhm.
So I really feel like I have a lot of information to give families. And a lot of the lactation consultants here will refer those cases to me like, okay, we don't know what to do. And I feel like if I can get them early enough, we can really make a change. And we're
Right.
getting babies that are told, oh, yeah, your baby can't breastfeed to get to the breast.
Mhm, mhm.
So it's
Right.
great.
Yeah, we take that more, pre-feeding and oral motor side of things and can recognize that sometimes it's deeper than just a latch that's not good and, trying to figure out how we can fix that, utilizing what we know as speech language pathologists working with babies can be really powerful.
Absolutely. And sometimes just, using common sense too, like, okay, that baby can't sustain a latch of the breast. You know what? Let's use a nipple shield. And sometimes we use a nipple shield and that baby gets on the breast and it's just a bridge to breastfeeding. We get rid of that shield eventually. But I
Right.
use a lot of things like that. I'm a little more, I'd say quick to use them just because I know it's going to work and I
Mhm.
can always wean from using any type of support device with breastfeeding. And I think, having that speech pathology background really, really helps a lot because I definitely feel like I can see things that other people might not notice.
Absolutely. Yeah. And even with being okay with going to something like the shield and weaning off of it, we have that background as SLPs of like, let's cue them. We give them
Yeah.
visual, verbal, tactile, and then we'll fade it away. So it's just kind of how we think about things.
Yes, and I think a lot of times lactation consultants think if you use a nipple shield, oh, that's bad. You can't do that. But I would much rather see a baby at the breast with the shield than
Mhm.
not at the breast at all. And I have so much experience with doing that. And I use shields quite frequently with babies with Down syndrome. It really helps them stay on the breast. And
Yeah.
we always wean from them. It's not a problem to do that. So getting in there fast and getting the baby to practice at the very place that they're supposed to learn that skill at the breast versus doing a bottle instead can make a big impact in getting them to transition.
Definitely. Absolutely. So let's go into a little bit about your adapted baby-led weaning method. I know you have created this and you do a lot of teaching on it. So tell me a little bit about how, this came about, what inspired you to create this.
Okay, so way back in 2010, a colleague of mine who actually owns a lactation center in my town, I teach transition to solids classes, and I would teach for her, and I also teach on my own as well. And she
Mhm.
had attended a conference in Wisconsin, and Jill Rapley, the pioneer of baby-led weaning, was the keynote speaker. And back then in 2010, we still had DVDs, and she came back with a DVD, and she gave it to me, and she goes, "You have to watch this DVD. You're not going to believe this approach and how babies learn to eat solids." And she was really excited about it. And she and we're both kind of nerdy, like we love new things to learn new things. So I'm like, okay. I took it home and it was a 23-minute video.
Okay.
And Jill Rapley was narrating, and it took you through exactly what you do from 6 to 12 months and using baby-led weaning. And I honestly was amazed at what I saw. Watching these neurotypical babies, I think the thing that really shocked me the most was there was a 9-month-old eating a peeled apple, and I could not believe it. And that child had skill. Like, we're picky about skill, right? And I'm watching going, I don't believe this. Like, these babies completely feed themselves. And I saw the therapeutic undertones of this approach. And I thought, this is amazing. How can I use this with my population? Because it has to be done safely. And my population needs support. That's where the idea started. So that was in 2010.
Okay.
And I work with a lot of babies with Down syndrome. And I am so tired of seeing 2-year-olds with Down syndrome being fed smooth purees, no chewing skills, tongue thrusting. Like, it's so frustrating. And I thought, what can I do? I can make this better. So I started really looking at different foods, looking at the properties of different foods and thinking, how can I offer these things to babies where it's going to facilitate skill safely give them some nutrition, and help them advance forward so they can be eating foods just like all their neurotypical peers. So that's really how it started. And I remember doing it with some kids with Down syndrome. And I started with using some silicone feeders. Those are those little pacifier looking things with the holes in it to safely work on chewing. And over time, I just figured out a very systematic way using different shape, size, texture of table foods, family foods to offer to babies that would facilitate self-feeding and facilitate chewing skill development. And that's really how it happened. So back in 2010 is when I, was kind of experimenting with it. By 2016, I had a pretty good handle on how to do it. It was much more systematic. Okay. And I remember I gave a conference here in Illinois to speech pathologists on feeding. And before I started, some people that were friends of mine came up to me and said, we just want to warn you. A lot of people in the audience, they think what you do is dangerous with baby-led weaning with kids with feeding issues. And I kind of laughed because I thought, no one's ever told me I've done anything dangerous before. I thought that was very interesting. No one had ever seen actually what I did, right? It wasn't like I had a social media platform at that time. So I just remember thinking, okay, I kind of banked that information. And I thought, I really like to see what they see by the end of the day when they start seeing how it is put into play. And I think that kind of started to put the idea in people's heads oh, maybe this could be safe and therapeutic, and this might be a great approach. The thing that really launched it out there was in 2018, Lori Overland and I were at a Christy Gatto course in New Jersey together. Oh. We didn't know each other. I knew who she was. I'd taken all her courses, and we were like the two old ladies in the course. And we both worked with 0 to 3 and Down syndrome, and we really hit it off. Wow. We ate lunch together every single day, and we were talking about baby-led weaning. I actually have a funny story about that. One of the participants said, "What's baby linguini?" And we thought that was so funny that she had no idea what baby-led weaning was, and she thought we said baby linguini. Anyway, Lori and I we became buddies over lunch. I was showing her, I was a little scared to show her, but I showed her some videos of what I was doing. And a couple of months later, she reached out to me. She goes, "I'm going to be honest. When you first showed me that stuff, I thought, this is crazy. What is she doing?" And she said, "I went back to Connecticut. I started doing some of the things that you were doing, and I really see the benefits to this. Why don't you and I together, let's do a talk for ASHA. Let's see if they'll accept us, and we'll combine the sensory motor approach that she did with my adapted baby-led weaning." And we spoke in Orlando at ASHA, and a lot of big people in the feeding world were in that audience. And I was terrified, but because Lori endorsed and believed in what I did, I think that it got other people to say, "Oh, maybe there's some value to this." So fast forward, the pandemic comes.
Okay.
And I did an adapted baby-led weaning webinar for Japan. Baby-led weaning is really catching on in Japan, especially in this group called Maoris. It's a group for people with Down syndrome. Okay. And there's a woman, Aya Takamura, who helps run this program. She asked me to do this webinar for Japan, and they recorded it. And Jill Rapley is a big deal there. They really love her in Japan. And Jill Rapley and I had been in touch. I had sent her videos of my work and what I did. I was terrified to send it to her too, because thinking, oh my God, she's going to hate these bridge devices. She's not going to think it's baby-led. And anyway, Jill and I were in touch. She did know who I was. They must have sent my webinar to her to vet it, to make sure the information that I was giving was legitimate. Well, she and I met via Zoom. She wanted to meet, and she said to me, "You have to do something about this." She said, "This is amazing what you're doing with these kids who have feeding issues." She said, "If you don't jump on this, somebody's going to steal your idea. And you've been doing this for so long. You've been doing it for 10 years now. You need to do something." And I said, "Well, what am I going to do?" I go, "Write a book?" She goes, "Absolutely." And I said, "I don't know how to write a book by myself." I said, "Unless you wanted to do it with me." Aww. And she goes, "I thought you'd never ask." And that's really what did it. We did a little presentation to the publishing company that her book was published for. They realized that this was a niche area. Nobody had published a book on this. And she and I, it took us 2 years to write the book. She would write during the day because she was in the UK. And
Oh,
at nighttime, when I was done working, she would send me everything. I would write at night. And it took us 2 years and a lot of Zoom calls and a lot of, lot of meetings to discuss how we were going to put it together. And by August of 2022, the book was published. And that's
wow.
how it happened. Yes.
Wow. What a journey for you. Oh my
Yes.
goodness.
And,
Like
and I
12
just,
years of
I,
working on that.
and I feel so lucky. Like I can't even believe it happened. But I will say that 23-minute video that I watched in 2010
Yeah.
changed the course of everything I do with feeding. Like I really don't believe that any child needs to be fed by an adult. I feel that all kids can do this. Obviously, there's situations, motoric situations where some kids cannot, but in most situations with the right support and the right feeding therapist that knows how to guide families, most kids can do this and do it well.
Yeah, definitely. What are some of the key concepts you would say with the adapted baby-led weaning?
Okay,
For anyone
so
that doesn't know, baby-led weaning is when we are giving table foods, whatever the family is eating, we're providing it in a safe way to the baby. When it can start as young as 6 months, correct?
exactly. And
Yeah.
with traditional baby-led weaning, we do a lot of things in like strip shapes. And a lot of the eating in the beginning is not really for nutrition and volume intake. It's just learning skill. And that's what a lot of people have to get in their head. Like they think, oh, the second you start, baby needs to be taking in all this volume. Absolutely not.
Right.
Breast milk and formula are still going to be the primary sources of nutrition up until 9 months. So a lot of it is working on skills. So traditional baby-led weaning is baby eats all family foods, offered often in a strip shape in the beginning. And here's one thing I do want to clarify, because this is a huge misconception about baby-led weaning. People think that anybody who advocates for baby-led weaning is anti-spoon and anti-puree. That is 0% correct. I have been kicked off moms' Facebook pages where people will tag me because their child's struggling with baby-led weaning, and I'll talk about using a preloaded spoon, and they kick me off because I mentioned a spoon. Doing a preloaded spoon with like a mashed table food on it
Yeah.
is baby-led if you hand it to the baby and they feed themselves.
Right.
So, right. So what we don't believe in is we don't believe that we have to feed a baby ever with a spoon. We believe that the baby can do it themselves. We also don't believe that you have to go out and get a store-bought baby food. You can just take a banana and mash it. You can take an avocado and mash it. We just don't believe that you need to do that. So we are not anti-spoon or anti-puree. I use them all of the time. I just let the baby do it, and I use a lot of table foods. I'm using family foods.
Yeah.
The other difference with adapted baby-led weaning is in the beginning with some of our children that have more motoric challenges, we might have to do more facilitation where we help them go over that pattern of hand to mouth using preloaded spoons, using strip shapes of food. We do a lot of firm, what we call food teethers. We actually will do like a raw carrot and celery because those babies do not have the jaw strength to bite through those things, but they're getting lots of jaw work and hand to mouth practice. So we might do some facilitation. The other big difference is we use a lot of these bridge devices. So we use a silicone feeder, which looks like a little pacifier with handles. And I'm really picky about ones that I use. I'm a fan of Easy Peasy's gumline feeder. And I also use something called a panda fruit feeder. And with those feeders, it's a bridge for hand to mouth, because it allows babies to bring things to their mouth more easily. It's also a bridge to chewing. So what that means is when you start initially with those silicone feeders, you're going to use an easy food. So when that baby exerts gentle pressure on banana in that feeder, it's going to easily come out. As time progresses, you're going to use that as a bridge to more difficult foods. So you might put some frozen fruit in there, like a frozen strawberry, or later chicken or steak, or you might put in a whole bunch of Cheerios. You're going to work your way up to more difficult foods that require more jaw strength and pressure. So you use that as a bridge to more difficult foods. It contains it in that silicone feeder, and it makes it safe for those babies that are learning skill until they get to the point where you're like, this baby has better skill. We've really been working on chewing in a lot of different ways. And then that baby can start to do those foods outside of using a silicone feeder. And we get rid of the feeder. It's just a bridge to get us there safely and to teach children skill. I actually, on my website, I have a digital download library of all the different categories that I use with foods. I have something called partially exposed foods, where you might take a pear and you peel one side, a really ripe pear, and you let the baby gnaw on it. with their lower jaw and upper teeth to do a little bit of scraping for graded jaw movements. I have lots of different categories, and I'll use those different categories depending on where that child is developmentally in their skill. So that's one bridge device. We do frozen straws, which I learned from Lori Overland, where you take silicone straws and you fill them with a puree and you freeze it, and that works on up-down chewing movements and resistance. I use mesh feeders where I'll put small pieces of food and place it on the first molar for more sustained chewing. So we do a lot more therapeutic feeding, and a lot of that comes from my knowledge from taking Lori's courses and just using that for chewing skills and using it for self-feeding skills. So there's a lot of different steps in between. It's more systematic when you do adapted baby-led weaning, because we're looking at skill. So we're picking foods mostly to work on facilitating skill development and keeping it safe. Whereas with traditional baby-led weaning, lots of people will just put anything in front of them. I will say, though, that is one of the reasons that traditional baby-led weaning does get a bad rap, because parents don't always know how to pick foods that are appropriate for their kids' level. And I've seen lots of people posting on social media, oh, my 6-month-old was eating macaroni and cheese. No 6-month-old is eating macaroni and cheese. If they're putting it in their mouth, they're gagging it out or pushing it out with their tongue, because they are not going to have the skill to manage that. So they may be tasting and exploring that food and gagging on that food. They're not really eating it. So I think that we could do a better job of teaching parents how to select foods safely for their baby's skill level. There are some really great professional sites out there that really teach families how to do this, like Baby-Led Wean Team, Solid Starts.
Yeah.
They're great, but I feel like where we're lacking most is really teaching parents exactly how to do this and in what order. And some kids, they could be neurotypical, but have more sensory issues and be more sensitive and don't like certain food textures. And you have to know how to pivot with those kinds of kids too. Those are the kinds of kids that are going to benefit more from an adapted baby-led approach.
Definitely, yes. And when you're doing the adapted baby-led approach and you're working with, say, a child with Down syndrome, are you still typically starting at that 6-month mark? Or are you looking at it from a more, developmental skill level?
That is a great question. So here's what I will that is one of the things I love to tell everybody about. Children with Down syndrome, if they are started right from the onset at birth with a feeding therapist that starts working on pre-feeding, helping facilitate breastfeeding, helping to create more qualitative bottle feeding skills. If I start with a baby from an infant, most of the time with those children with Down syndrome, unless there's a lot of medical complexities, I can start solids with them at 6 months.
Wow.
Because I'm working very hard with a physical therapist. We're doing all the gross motor foundational work. We're doing a lot of pre-feeding stuff, a lot of hand-to-mouth work. I'm even helping them pick teething toys and all the things that they need to do in preparation for solids. And I usually can start at 6 months. If they don't get that work, they're often going to start solids later, 8, 9 months, just because of the fact of the motor being so delayed. And obviously we can't start too early if a child can't sit upright in a chair. But I will say, with some of my babies with Down syndrome who aren't sitting up independently, we will sometimes put them in a bouncy seat, but we really elevate the top of the seat. We push the base of the bouncy seat into the bottom of the couch, and it pushes the top up a little so they're more upright. And we just do food strips and food teethers. So we use food as a teething toy. So that's really, and then parents feel really good. Like they feel like, okay, we're actually kind of doing solids, even though we're not, adding any nutrition in terms of swallowing. You're still tasting and exploring foods and working on hand to mouth.
Right. Yeah. I find too, and let me know if you agree, that when a baby does have a diagnosis like Down syndrome, it almost allows for everybody in that baby's life to be more proactive and know, this is what we're going to see with this diagnosis. So it's so important that we start from birth, compared to when we have a child that maybe doesn't have a diagnosis like that, and they don't get that advantage of being proactive from the start.
Yep, I 100% agree with that. But yeah, we know that, Toni. But What do we see? I see kids that are not getting services in EI with Down syndrome until they're 12 months or older. You've just missed 12 months of intervention. And babies with Down syndrome, they're going to need support. They're going to need support. So if you can get in there early and teach parents what to do, oh my goodness, like my babies that I start with Down syndrome, they all do great with adapted baby-led weaning. They're all self-feeding. They're eating family foods. When I get them after a year, it is very difficult to undo what has been done. A lot of them have been so used to someone feeding them. They refuse to self-feed. They refuse texture. So any feeding therapist out there, you need to be working with them from infancy. If you don't know what to do, I really suggest you take some of Lori Overland's pre-feeding courses for babies with Down syndrome. She has great coursework on kids with Down syndrome. I have a lot of courses on my website that people can take. Lori and I did one together. So it's really important that these babies with Down syndrome are seen very early on. It really makes a huge difference. I want those days of 2 and 3-year-olds with Down syndrome being spoon-fed purees by an adult to be gone.
Yeah.
Because I just don't think there's any reason for it.
Well, it sounds like you're doing everything in your power to make that happen, which is amazing.
I'm trying.
I know. So also with the baby-led weaning and, utilizing adapted baby-led weaning, I find that with parents, many of the times they are so interested in it. They totally understand, the why, that we want them chewing, we want them eating, we want them not on processed foods. We have a lot of families now that are very organic and holistic and want to, give their babies the best nutrients. And they're very interested and they want to do it, but they get a little scared. They're nervous of that choking and, how do I make sure I'm doing it correctly? And I love some of the resources you said that kind of help give the parents that extra confidence of knowing, follow this. And some of them outline it for like weeks and week 1 and week 2, which can be really nice for families. But what would you say to the parent that is, a little scared about the choking or the gagging? I mean, I always like to say to my parents, when this baby is, 4 or 5 and they're learning to ride a bike, they're going to fall. That's just part of the process. So as we learn to eat, gagging is part of the process, and it's actually a good thing. It's a protective thing. It's how they learn. But so many times their baby might gag and now they get so anxious, and the baby picks up on that anxiousness. And, sometimes we have to just like calm that environment for them.
100%. And I think that part of that is people mistake gagging as choking. So you have to teach them what the difference is. And that gag reflex is really important from 6 to 9 months because it's so protective. And actually Solid Starts, has 2 occupational therapists that do a great little video about the protective part of reflexes and why it is so important to start solids between 6 to 9 months to utilize and those reflexes because they're going to be helpful. But here's the thing that happens. Parents see those gags. They freak out. Sometimes it is because they're giving foods that are inappropriate for that child's level, or they're not recognizing that their child is experiencing some sensory issues with whatever they're offering to them, and they need guidance. But a lot of people will abandon baby-led weaning when that starts. So that's why doing it systematically is important. I have a on-demand pre-recorded class for parents that takes them through exactly what they need to do and how to go through this process. But again, it's always going to be individual to that baby, but at least it gives them a foundation. It's a great accompaniment to the book. I have that digital download that shows all the categories, and I am currently almost finished. I have a video library for every category of my approach that walks a parent or a therapist through. This is how you prepare the food. This is why you prepare it this way. This is why you offer it this way. It's the visuals are great. It's taken almost a year to put this together, but I'm very excited for it to be out there because I think that anybody who has the book, if they're really like not sure, okay, how do I do this? That video library is going to take them right through what they need to do. And there's also in the book, there's a photo insert in the middle of it that shows every single thing in the book that we talk about, how it's cut, how a child's holding it, managing it. So it's all of those things together are helpful. But I do think that parents really need a qualified feeding therapist that can guide them safely on how to do this. Because I do see a lot of parents send me videos and I'm like, oh, not
I know.
using appropriate food for their child's level. And
That's
you don't
right.
want to make them feel badly, but you also don't want their child to be eating things that are unsafe. So it is really important that we teach them the right way. I have a 2-day professional course I've done once
Okay.
that for professionals and how to do adapted baby-led weaning. I feel like it was really, really helpful. I'm going to try to do that again in person in the future. I'd like to go around the country a little bit and do that. And then once I do that, I'd love to do Zoom groups with therapists who are kind of stuck. Okay, here's the kid that I'm working with. How do I do this? And I feel like that would be a good next step to, I feel like the parents are really on board. It's the therapists that are really reluctant, like, oh, that's too dangerous. And they don't want to learn new things. And they don't realize that this could help their patients so much. It really can.
It really absolutely can. And I hope that you do put that into action. And I hope that you add New York to one of your top places.
I'm from New Jersey originally. I'm
Oh,
there.
perfect. Okay, good.
Yes.
So you have to
I'm,
let me know when you do that 2-day. I'm definitely there.
yes. I'm coming for the pizza and the Chinese food for sure.
I'll bring you all you want. That's great. That video library that you mentioned, that's on your website?
Yeah, if you go to the resources page on my website, you can see the digital download and the video library. I'm working it with my web person. It should be done. We're hoping by midsummer. Like we're really close. I'm just now like we're putting all the videos together and I'm doing the scripts. It's just a lot of work because I want to make sure I have the most perfect videos that are going to demonstrate exactly the point that I'm trying to get across. But then they'll have the digital download to print out, and then they'll have that video library. And I feel like I feel like if you are not sure what to do and you live out of the country or out of state, it's a great jumping off point for sure.
Absolutely. Yes. And again, same thing, nothing that we learn in graduate school. And I take on externs and clinical fellows. And it's always, this is such a beautiful area of our field that it is I'm back and forth with it on the educational side because I do feel like this is a specialty and maybe this is something that the training is best after you've graduated your license and you have some experience in the field. But it's such a rewarding, amazing area that we get to do as speech language pathologists. And never do I have a therapist that isn't like, I love this. I can't believe I didn't do this for the first 5 years of my career because it's fun. The babies love it. You see their progress. You help families just feel so much better. And it's just so rewarding.
It is. And I work closely with a dietitian, and we have so many kids on tubes. Like, there's nothing more satisfying to see our really sick kids that are G tube dependent that transition away to all solid foods and family foods. We had a little girl that we worked with named Millie, who was in the hospital until she was 8 months of age. She had Down syndrome. I started working with her at 9 months. She had a G tube. She was so medically complex. There were so many times that they didn't even think she was going to make it. And she is one of my best eaters. And the whole approach really helped her family. They're Mexican descent. And mom, when we were going through the allergens, we wanted her to do hummus to be exposed to sesame. And the mom had never had hummus before. And she's like, okay, now the mom eats hummus. So she said she's eaten foods that she's not eaten before. She feels like she eats healthier. And the other thing is, when we started this, her family members were like, what are you doing? This is dangerous. You need to stop it. Just feed your baby. Now they all marvel at how she eats. Like, they can give her any family food and they just watch her like they're amazed by her skill and her interest, and she eats what everybody else eats. They can go anywhere and whatever they're eating, she eats. So it's just so nice to see that and to see how not only does it change the baby, it changes the rest of the family. I've even had situations where older siblings did not do a baby-led approach and were pickier, and they see how much fun the younger siblings having with the parent, that it encourages them to eat differently or eat foods that they wouldn't try before. So it's really nice.
I love that. It really is. And, as a therapist that does a lot with myofunctional therapy, it also brings us to the fact that this is getting children and babies to chew. And we know that chewing is what helps to develop the jaws and the airway. So, it's all related. And when we're seeing the 5, 6, 7-year-olds for myofunctional therapy and they have narrow palates and a recessed jaw, and we go through their diet inventory and things from their past feeding history, and we see that they, maybe didn't start solids at 6 months old, or they were only on purees until they were 9 months old, and we've kind of missed that important chewing side of development.
Absolutely. And a lot of baby kids and people don't know they're sucking on their food and not really chewing it. I see that a lot. But I actually want to go back a little bit. I have an interesting story about oral myofunctional therapy. This is actually the whole reason I became a speech pathologist. When I was 10, I went to the orthodontist. It's that time to maybe get braces. And he said, nope, you have a tongue thrust swallow. You need to see a speech pathologist. He sent me to a speech pathologist, was a man, so unusual. And I was one of those kids. If you told me I had to do something at home, I was going to go home and I was going to do it. So he taught me how to elevate my tongue to the roof of my mouth for swallowing. And I had a big space between my front teeth, and I had an overbite.
Okay.
I worked with him for 3 months. The space between my teeth closed and the overbite shifted just by changing the place of my tongue for swallowing.
Wow. And at 10 years old.
Isn't that amazing?
That is amazing.
So I'm like, I just had to change the position of my tongue for 3 months, and that makes all these changes. Guess what? I never had braces.
Wow.
I never got braces.
Wow.
Isn't that so that I thought that was the most miraculous thing ever. So people who say that, they put down oral myofunctional therapy, oh my God, it was magical for me. And when I saw that and how you can actually change your face just by doing that one thing, amazing. So think about that. If we do all that chewing, all the time on firm foods, working on making that jaw stronger. Like there's so many things that you can do. The way that we eat actually can shape our face. So to me, I so believe in it. And those things all go together. They're absolutely connected. And that's what propelled me into the field, honestly.
Wow, that's amazing.
Yeah. Mm-hmm.
You have so many good stories from, this whole journey for you, and your journey is just keep going and going. And I am so grateful to have you in this field, and thank you for everything that you are doing for this field.
Thank you. I love it. I'm going to do it until I drop. I love it. And I just have to get more people interested in doing this. Therapists have to realize this can be a game changer for their clients. So thank you so much for allowing me the opportunity to talk about it.
Yes. And if there is anyone listening that wants to try to just learn everything that they can, would you say that your website is a great place to start?
Yes, they can go to my website, which is jillrabin.com. They can also go to my Instagram account, which is at Jill Rabin, ABLW. There's a lot of videos on there showing journeys of children with different diagnoses and how we've done adapted baby-led weaning. I often advertise courses on there and classes on there. So yes, those would be the two best places to go.
Awesome. Definitely check that out because you can learn so much from Jill. And thank you so much for being here with us today. And I look forward to seeing you again soon.
Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Wyo Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.